Hello, good morning. I'm Tania Pombeiro. I'm a family therapist within the under 25 services. And today I'm filling in for my colleague, Jo Percival, who works in the under 18 eating disorder service. I think that when she rang me yesterday night to apologize for not being able to be here, I felt a little bit anxious because I didn't know who I was going to speak to. So I didn't really know what you would like to hear. So bearing in mind that I feel a little bit like the X Factor now with the camera and the microphone, and I absolutely don't know how to sing, you have to bear with me. Yeah. Can I just, if you feel comfortable, just a little bit of a show of hands to about who works with eating disorders as a professional here? Except you?
I have done.
You have done? Fantastic.
As far as I know.
Fantastic. Who is a carer or a parent of someone with an eating disorder? Fantastic. And who knows anyone with an eating disorder? Yeah. Fantastic. So I have some ideas about eating disorders and about the work that we do in the under 18 service. But please feel free to interject and to tell me what would be more relevant from our conversation right now. Yeah? So like John, a little bit, you know, I can talk, and I can talk for a long time. So I need your help to be a little bit boundaries in what is relevant for you. Is that okay? So, as you know from my accent, I wasn't born in England. And I was born in a place where food is a big thing. And when we talk about eating disorders, we talk about food in the first instance. And we talk about a disorder of eating. But food is fundamental. Food is like the ABC of our living. And it's very crucial as a source of energy. And it's very crucial in terms of our body being able to function. At the same time, food is the means throughout we socialize and we communicate. And if I think about my experiences growing up, we do everything through food. You know, you are born and they bring you food. You know, you are christened and you have food. And you go to school and there is a party with food. You've got birthdays and you know, you can't have a birthday without food. And you are with friends and family and you've got food. And you're trying to develop and being a child and express yourself and there is food and there is mess. There is so much happening through food that eating is such an important aspect of people's lives, and it's a relational and it's an emotional aspect of people's lives. So it makes sense that we think about it. Now, how do we think about, pardon me, the people that have a reaction to food? A people with whom food reacts in a not a pleasurable way. And how do we think about how we provide care for people that have a difficult relationship with food, and through food also have a different relationship with the world and with ourselves? How can we provide a service? How can we help people to develop their identities when something that is so fundamental to some of us is an issue of the stress and causes difficulties and causes so much impact to the people around them as well? This is what we've been thinking about. And we've been thinking about it as a service, and we've been thinking about it with other charities like Beat and Eating Matters and schools. And we've been thinking about how can we do that to the best of our ability to make sure that we provide a good service. So, and I was kind of very curious about the question that I was hearing about services and how services are commissioned, and the way that eating disorders are diagnosed. You know, criteria change. And what we're trying to do is we try to work with all the teams around us to try to provide the best service possible according to the way that we're commissioned, but also according to our capacity. there are lots of different disorders of eating. In the service, we mainly see anorexia nervosa or bulimia or some kind of atypical presentations, or in some other cases, some kind of avoidant restricted disorders. Now, we might work very intensively with these three big ones, but it doesn't mean that we don't recognize that other disorders or disordered eating also exist. And what we then try to do is try to work with other agencies, either like BEAT or Eating Matters or the Youth Service, to try to, or CAMS, to try to provide a service for the young people that suffer from those illnesses as well. So we might end up working and liaising and consulting with learning disability services. We might end up working with school nurses or with CAMS for those issues here, so that they can also provide psychological minded services for those young people, because I recognize that the BMI is not the criteria for the diagnosis. The diagnosis is just one criteria. However, what we've been realizing, especially in the last couple of years, is that anorexia nervosa is the most commonly as its onset in adolescence, with up to a quarter of its first presentations occurring in childhood, which is quite a big thing. So we see younger and younger people being referred to services in a real serious condition. And we also see younger people that either don't have the language or they don't know how to express themselves to come up with descriptions that you find in books to say, this is what anorexia looks like. They don't have that language. No, I've got a problem with how I look. They don't have that language. So they express themselves through other ways. And the way that they also experience the illness, it's very different. Very different. So, for example, you would have an 8-year-old perhaps complaining about tummy aches, complaining about tiredness, not being able to do the things that they usually were able to do, not wanting to go out with friends, having lots of headaches, and feeling really, really lethargic and not being able to concentrate at school, being miserable. And then you see that they would kind of lose weight or they weren't thriving. Now, we wouldn't just look at the BMI, but we would need to think about how can we provide a service that is appropriate and that is psychologically minded as well for those. And how can we work in partnership with the agencies around us to provide support for that. And like I was saying, we have been very, very surprised to see that up to 51%, perhaps recently more than that, the young people that we're seeing from the ages of 12 to 14 arrive to us to the first point of contact. So the first assessment that we would do to them, so compromised that sometimes we have to send them straight away to accident and emergency. So they're arriving to us in a more and more compromised state. And this is causing us some serious concerns. But we're also seeing that this is happening nationwide as well. So they will come to us, not just in the beginnings of starting to lose weight or starting to feel bad about themselves or wondering about where they are in the world. They would arrive to us and people would only find out about their struggles when they are really, really compromised. Low heart rate, low blood pressure, hypothermia, sometimes in a very, very risky situation. Some other times presenting to services like the youth service with self-harming or with suicide attempts because, you know, they just have it. It's too difficult for them. So that kind of makes us think about how can we then, as a hopefully we will become more resourced, John. But with our team right now, made up of 5 people, not of all full-time. I think we only have 1 full-time person in the team, covering at the moment about quite a huge population. We really need to think about how can we gear up our resources for the ones that are right in the more compromised state. So this will be the anorexia, in some cases of bulimia as well. Say that to meet criteria for anorexia nervosa, you need to see a restriction of energy intake relative to the requirements. So basically, in terms of energy, you waste more than the one you put in. Yeah? So you exercise more than what you eat, or you don't eat enough for the kind of energy spending that you need, which leads to significantly low body weight in the context of age, sex, developmental trajectory, and physical health. This means that for each person, their presentation is different, because their body is different, their age is different, their signature of development is different. So we need to see each person as a person on its own right. They will also present with intense fear of gaining weight. They are fearful of gaining weight or becoming fat. Or they present with a persistent behavior that interferes with gaining weight, even when they are really at very, very underweight. And there is also a disturbance in the way in which one's body weight or shape is experienced. So they have kind of difficulties with their own body image and the way that they experience their own body. Or they have a lack of insight about the seriousness of the current low body weight. Now this is another problem, because sometimes we think about it, and you were talking about carers, I think it was you, and you were talking about how can we then help a young person that has any insight, that doesn't recognize that they have a problem. How can they go and ask for help? Who do they have contacts with?
But the parents would notice, most parents would notice early, I'm sure, that there was something not right about their, do they not?
That's the hard bit.
Because that just correlates to the fact that if they have to be at a significantly low weight to be diagnosed, that's why they're turning up to you in such a state that if it was recognised early, even though they might not meet the criteria that they're not yet underweight, that's what's going to happen if they're not caught early. Is that a problem, that they're getting into the system, they're only getting into the system when they are significantly ill because they're being rejected before then?
No.
The problem, it's not being picked up.
I think it's a little bit more complex than that. I think we're talking about teenagers, that especially teenagers, not so much the under-8s, but teenagers. I'm a mother as well, and I know, or I've got an expectation that when my son starts high school or grows up, I need to give him a little bit more independence, and I need to give him a little bit more space. That's appropriate. That's me doing my job as a mother. This means that they spend more time on their own. They have more freedoms to wash, self-care, choose their own clothes. And they spend a lot of time doing what teenagers have to do. At school, with friends. We also have busy lives. We work, we get home, we have our routines. So actually, even though it's almost kind of expected, and that's one of the big things about this illness, people come to us and then think, how did I not see this? And then they feel really bad about it. And then we also have to think the other way around. How were you supposed to? Because it's really difficult. And this is also a very secretive illness. So you wouldn't have a young person really showing you the signs. You would have a young person that doesn't recognize the illness, or that he or she has a problem, but recognizes that it is engaging in behaviors that parents or carers or friends might not be tolerant of. So they hide them. So it's a really tricky game, isn't it? The problem with not, in terms of being referred to services, in terms of being referred by GPs, and I'll explain why we need a referral from GPs, and we'll also accept from others, but we need information from GPs. From being referred to GPs, the first referral into being offered a first appointment to our service, it takes about 2 to 3 weeks. So it is a sign that this is a really tricky illness to capture, and also a very tricky illness to offer a service for. And the need to work alongside other agencies, and the need to actually be able, like John was saying, to try to figure out how we're going to manage transitions, not just in terms of helping young people in terms of their development, but then helping them throughout their recovery. Because we're very much focused about having a vision and thinking about recovery, and thinking about how can we support you and the people around you towards that path. So if these are the diagnostic requirements, and I don't want to bother you a lot with those things, but if we think about physical symptoms and risks, this is quite a tricky thing. So we're talking about, well, severe weight loss, weakness, hair loss, you know, the yellow tinge to the skin or to the eyes, lanugo, feeling cold. Now, how would you know that your son or your daughter is experiencing one of the symptoms if they wear boots? You know, they wear baggy clothes. It's fashionable. You wouldn't think about it straight away. You would think they're trying to express themselves. But then you would also notice that they are really low in energy. They're fatigued. They're irritable. You know, they push you away. They try to avoid you, and then you think, oh, there's a lot of stress about exams. He or she needs to rest. Let's give them in their bedroom. That's normal. Then they also start experiencing stomach pains, constipation, bloating, which kind of adds to the experience that eating is not a really nice thing. It's a yucky thing. And then they start having other more serious things, like low blood sugars that can result in confusion, tiredness, sometimes even coma, seizures, arrhythmia, death. This is serious stuff. Reduction of bone density. For girls, the periods stop, or they might not even start, which kind of needs follow-up. So this is a serious thing. But it's really difficult sometimes to pick up and then to refer into services. Again, this is an illness that, and I'm a kind of a therapist, I'm not a doctor, so I kind of feel that I'm kind of jumping into someone else's field. But, you know, one of the reasons why we need to work so closely with GPs and also help them to refer early on is how it compromises the heart. And this is why it's so serious. So all of these things that you'll find in foods and water and drinks, not having them can compromise your health in these ways. And that's why it's so serious. And this is why when we think about an eating disorder and we think, is this a social thing? Is this a psychological thing? Is this a biological thing? Is this a phase? It's probably all of them. However, when things are really tricky, it is a serious physical condition that needs to be treated at that time. And then when they are in a better physical state, then we can address the other things as well. So we need to think a little bit like a pathway. If we think about bulimia, on the other hand, we see several episodes of binge eating, meaning that they eat much more food than would be expected. During like a similar period in time, like in a meal, they would eat, you know, stupid amounts of food, and you wouldn't expect them to have that, or a person of that age to do that. But you also feel that they do that, and it's accompanied by a sense of lack of control, and they're not really comfortable. There is no pleasure associated with that. And they find themselves having to engage in that behavior and then having to undo it. So they have a recurrent behaviors that are aimed at undoing all of that binging. And that can be vomiting, use of laxatives, diuretics, or other medications, not eating, or then exercising as well. And then you'd have recurrence as well. And you'll say as well that all of these behaviors have to do with also the fact that they have a negative view about themselves in terms of their body image, but also a very negative view of themselves about their worth, about how other people see them, about who they are in the world. And this almost kind of becomes a coping strategy, albeit a very difficult one. In terms of consequences as well, there's all of this list, which is quite a serious stuff, again. And we're only thinking about physical consequences. We're not thinking then about the psychological effects, the effects to one's identity, not just by experiencing a period in their lives where they have to suffer with this, hide it, but then also the fact of having to go through recovery as someone that suffers from this. So we have to work really hard about, how can we think about your reaction to food, and how can we help you to have a different relationship with it. So the guidelines that inform our practice, that say, this is the best intervention, this is the best practice in the field, they suggest that the assessment of people with eating disorders should be comprehensive and therefore include physical, psychological and social needs, but also a comprehensive assessment of the risk to self. What's the impact of all of this on one's health, or the behaviors that they might engage in as well that might be risky to themselves as well. People with eating disorders should be assessed and receive treatment at the earliest opportunity, and this absolutely kind of backed up by all the research. The earliest that they are identified in treatment, the best outcomes of treatment we have. And the level of risk to the patient's mental and physical health should be monitored as treatment progresses, because it might increase. For example, following weight change or at times of transition between services in cases of anorexia. So we need to try to work really hard together to try to kind of manage these times when young people receive services from, for example, the child and adolescent mental eating disorder service, and then they transition to the adult eating disorder service. And we already identify patients that might be eligible for transition, and we meet with the services 6 months before they are supposed to move up to the adult services, so that they are identified, then they start linking up with them, so there is a connection. We also try to work very collaborative with the youth service as well, so sometimes even though they go up to the adult disorder service, they still receive some support from the youth service. So the workers or the people that are meaningful to them, they continue involved in their care. So they don't need to say goodbye straight away, especially with a population for whom making relationships is very difficult. So we try to work really collaborative with that. So with that in mind, and if we think about what the Central Norfolk Child and Adolescent Eating Disorder Service is and does. So we work with young under 18s. Our referral, we accept referrals from different professionals, but we need information from the GP. So we can have a professional contacting us, but we would be suggesting that the young person goes to the GP in the first instance, or that the parents take them to the GP in the first instance, so that we have all the other indicators that help us to measure what is the risk to their physical health straight away. So we wouldn't need just weight. We would need blood pressure, we would need blood tests, we would need to know their developmental trajectory as well. So that's why it's a very good starting point. And we also need to know it's not just what weight do they present at the point of referral, but what's been happening to that weight over time. And usually GPs have that information available. We are a multidisciplinary team. We're not a big team, as I said. So we have doctors, well, a doctor, a psychiatrist, 2 nurses, and a therapist. And we work part-time. Hopefully, we will grow. But we have to work really intensively with these families as well. And it's really difficult to do so when we have to work with many, and we're talking hundreds of families at the same time. In a summary, the interventions that we provide consist of kind of medical and physical monitoring, even though we work closely with the GP, with Norfolk and Norwich. Psychoeducation, individual support or therapies, including CBT for eating disorders, cognitive remediation therapy, motivational enhancement therapy, group work, family therapy, family carer support. So this is very much, like kind of John was saying, not just to think about the symptoms and the illness, but what can we do to help you to recover from this? And I've got a consultation to think about all the work that we need to do when we try to, even though we are under-resourced, to reach out. So reaching out for us would mean to try to go to people's houses and sometimes support them in managing meals together, going to school and meetings with school to help the teachers or staff to know what to do in situations like that. We have clinics in schools where there is a high prevalence of eating disorders, and sometimes we see young people in schools, or they know that they have an open door. So if they are worried, or they know someone, and they are worried about someone, they can go and talk to one of us. And we try to work with all the other teams, so the under-14s and youth service, and school nurses, to try to identify people at the earliest opportunity, and sometimes try to give them some information as well of how they can continue to support the young people. This morning, when they had to have breakfast, that breakfast was served with high anxiety. It was served with stress. It was served with noise, and noise, and noise, and noise, and noise, and noise. So they will be trying to eat, and they will be trying to function, and they will be trying to think of how they are going to manage the day ahead of them, and that they still need to eat. And inside their heads will be this noise, and noise, and noise, and noise, and noise all the time. So eating is not a pleasurable thing. So no wonder that they don't like it. Even more than that, sometimes eating makes the noise come down. So why would you want to stop eating? Why would you want to stop doing something that at some point seems to help you manage all of that noise? And that's why when people just say, just eat, it's not as simple as that. There's a lot of noise. There's a lot of thoughts. There's a lot of fears. And that's why, if people are as vulnerable as they are, at those times, we need families. And families are absolutely as crucial to them as for this. And we need family to help us to look after them. And we also need to have services that can be helpful for families. And I think that, when families come and see us, they sometimes feel that they're going to be criticized for not kind of picking them up earlier, or that they're not going to be supported. And there's been a lot of things written about families, the families that cause these things. Well, that's absolutely rubbish, let me tell you. Families are not part of the problem. They are part of the solution. So we really need to work with them. And I feel really strongly about that, not just because that's where my work really is. I guess that's my vision. I think that's John's vision, and I'm hopeful that's the trust vision as well. That actually that we see that recovery is not just something that happens between A and B, it's something that will happen, especially with eating disorders throughout people's life. You know, because there will be people that actually, especially if they are picked up earlier, can make a quick switch around and they can just start eating. There will be people for whom they have to learn how to eat as a means to actually be functional and do the things that they really want to do. And there will be people for whom eating will always be a really serious issue that will need a lot of input as well. So we need to have services that can be relevant for people that are different like that. So it doesn't mean that it needs to be a service that is equal for everyone, but like John was saying, you know, if we can provide intensive services right in the beginning, it might make a difference. They might then learn strategies to cope not just with the physical side of things, but then also with the noise. And at times they might feel, oh, I might need something else. And that's where my service and John's services and hopefully the other aspect of the adult services will come together and do that bit there. You know? And then we'll always need to have service for the most complex ones. So it's, you know, how can we have services that are relevant for people's needs as well? Yeah? I just had to share this with you because this was done by a family that came to us from the Philippines. And I worked with that family, and it was really nice to see them, and I've got their permission to share this with you, to go from having to move from this country, having to realize that their daughter had an eating disorder, because in their country there is no eating disorder. There is no such thing. So how would they be able to recognize it? And then they really had to work together and think about their resources as a family to then help the daughter to recover, and she's doing fantastically well. And they are evidence that actually being able to work with people earlier on and to try to provide them the support that they need and to try to be mindful of the resources that they can provide as part of the solution, and how they work so well with coaches, sport coaches. She liked sport quite a lot. The coach was really important. With school, with friends, with kind of the community. That really made a difference. So it's not just mental health services, but we're also part of the help that is out there. And if you can recommend the skills-based group that they run is fantastic, and we always ask our families to do that as well. But then we have a group of parents or carers or friends or siblings that come to us. The fantastic thing about that, and that I really like, is that we started running it, and now I just make the tea. That's my job. Because they run it, they own it, they know. And it's really fantastic when you are in a group of people and you see the most kind of senior parents, you have a family and they go, yeah. And they are such valuable resources in running that group. And what the parents and the carers say is, how are we going to deal with this behavior? It's relentless. And we talk about really difficult behavior. We talk about you sitting with your son or with your daughter, asking him to eat something. And they are going to be the opposite of what they know them to be. So it's tough. The effect on the family, the stress, the burden, the constant conflict, the divide and conquer that sometimes goes on. It's a big change. The negative symptoms. How am I going now to understand that my lovely son, that I loved so much, now doesn't want to talk to me? Spends all of his time in his bedroom or in the gym, or that runs away or self-harms or tries to kill himself if I force him to eat. How am I going to deal with that as a parent? Emotions run high. Not just feelings of blame, feelings of loss, feelings of self-hatred as a parent, anger, and their own feelings and the feelings that they then have to deal with coming from their own kids. It's difficult. So this is why I like this quote from Beth, and she says, you know, and I completely identify this now. If you have never been hated by your child, you've never been a parent. You know, and that helps me on a daily basis. So this is just, again, a summary of what family involvement is to work with you, is to talk to you, is not to say because she's 16 now we're not going to talk to you. No, we want you in the appointments with he or her. Sharing information, advice, working really collaborative with you and the people around the young person as well. So we offer family therapy, carers group, multi-family groups. We try to do what we can and what we know from research that tends to be more helpful. And this is a quote that I stole from the Beat website. They have really nice quotes there. And this is a young girl that said, I experienced anorexia from the age of 12 until I finally sought help at the age of 24. At that point, I was pretty desperate and hopeless. I thought that change would never ever be possible, and therapy was such hard work. It took a long time, but I eventually entered recovery, and I've never looked back. My life now is wonderful, and I never thought that possible. So it can be done. Yeah. And again, just a summary of references. There is BID, there is Eating Matters. There is a website from our trust about our services, about numbers, can be kind of developed a little bit. There will be the well-being website as well. You know, contact us. If you need help or advice, we'll always have 5 minutes just to have a chat.